Now there is something known as vaccine-associated poliomyelitis. It is a thing of concern because it is linked to immunization. So we are doing this, we are giving the vaccine in order to prevent paralytic polio. But what is happening is, due to the vaccine, since OPV is a live viral vaccine, due to the vaccine, we are having some vaccine-associated paralytic polio cases. So it's a serious but rare adverse event of the polio virus, but the clinical features are same like the wild polio virus. So the only way to distinguish is by lab analysis. Okay. So the incidence of vaccine-associated poliomyelitis is apparently 4 cases per 1 million birth cohort per year in countries which are using OPV. Okay. They're most frequently associated with Sabin 3, followed by Sabin 2 and Sabin 1. So Sabin 2 we have already removed from OPV since we were not having it in circulation in wild. So Sabin 2 we have removed from OPV. Sabin 3 we are still having, but the target is to stop OPV completely and shift to IPV entirely. Okay, in order to prevent any VAPP. Okay. So how to diagnose a VAPP? A VAPP has to be diagnosed by a RT-PCR. Okay, a real-time reverse transcriptive polymerase chain reaction. Now, VDPVs can be classified into 3 types depending on where they originate. So they can be classified as cVDPV.
মানে ওপিভিটা আমরা একেবারেই কমিয়ে দিতে চাইছি কেন ওটার বায়োঅ্যাভেলেবিলিটি কম করে
You are not audible, please be louder.
বলছি কেন আমরা ওপিভিটা একেবারেই উঠিয়ে দিতে চাইছি কেন বায়োঅ্যাভেলেবিলিটিটা কম বলে
No, we are wanting to do away with OPV because we are trying to achieve 100% coverage with IPV. So if we have 100% coverage with IPV, we need not require the community immunity that OPV produces by transmission through the community. OPV has that additional benefit that after vaccinating an individual, that individual will continue to pass the live virus vaccine through their feces, and that can confer immunity to the community by fecal-oral transmission. Okay, but if we are having a sufficient coverage of IPV and we are not having circulating wild polioviruses, then we can do away with OPV. Okay, because IPV is sufficient to produce the immune response. So we have started IPV already. We are trying to increase its coverage, and once we have a sufficient amount of coverage of IPV, we are going to phase out OPV, purely because OPV is associated with this VAPPs, the vaccine associated poliovirus. Okay. So VDPVs, they are classified into 3 groups: cVDPVs, iVDPVs, and aVDPVs. You need not know it in detail, but just know that cVDPVs are circulating vaccine-derived polioviruses, and these are arising due to person-to-person transmission in the community. iVDPVs are due to in immunocompromised individuals. So there will be prolonged infection in these people by the viruses, and they will undergo mutations, and that can lead to where it is not able to establish whether that particular VDPV is a circulatory or a iVDPV. Okay. So polio eradication